but the title is the Medial Patellofemoral Ligament, Friend or Foe, because that ligament is the most important factor in recurrent subluxation. This is a controversial subject, certainly in my country, because of the problems of disability following the recurrent or simple subluxation or dislocation. And there is no question that when you have a subluxation of the patella, definitive treatment is repair or replacement of the medial patellofemoral ligament and lateral patellar retinacular release, arthroscopy, and removal of cartilage and bony fracture fragments. The problem with that, particularly in the group of patients that I present to you, is that in athletes in competition, that requires at least 3 months away from activities of sports. And if you repair all patients with an acute subluxation or dislocation, there's a certain number of patients who will be overtreated and will lose time away from their athletic activities. The patellofemoral subluxation can be prevented in all cases by repairing the medial patellofemoral ligament. However, since in only 56% of our cases is the ligament torn, at least in our cadaver work, you have a certain percentage, 44%, who will be overtreated if you routinely accomplish surgery. The medial patellofemoral ligament is a active restrainer of the patella, particularly in 0 to 20 degrees of flexion. In correlation with the vastus medialis obliquus, it is probably 100% important in the prevention of recurrent subluxation. Although the Q angle is important, in this group of patients we found that that was not the case. These are college athletes, and they have been selected for their ability to perform, so that these college athletes, by exclusion, do not have a problem with hypermobility, varus, femoral anteversion, and other associated problems with recurrent subluxation. This is a study from one university, all competitive athletes, a randomized study of patients who lost time from their sport because of either an acute subluxation or an acute dislocation. So over a period of 1 year, we had 22 patients with a follow-up of from 18 to 45 months, a median of 29 months. Not surprisingly, because of the larger number of male athletes, we had 16 males and 6 females. We classified this group into 2 groups for purposes of delineating the proper treatment. This is inductive reasoning by stating that minor subluxations, in our view, prior to the beginning of the study, had a different treatment modality than did major subluxations. So the number 1 group would be minor subluxations, of which we had 5 patients, and those were patients with relatively minor trauma, evidenced by less than 5 cc's of effusion, negative apprehension test, and we used not only x-rays, but CAT scan and MRI to determine if there were free fragments. And on initial examination, they had an excellent range of motion of the knee from 0 to 90 degrees. And these patients with a minor problem on presentation, we treated only symptomatically, no immobilization, nothing other than exercises and physical therapy. The total follow-up time was 5.4 years, and all of these patients returned to full sports activities. This would be American football, soccer, baseball, basketball, all of our sports. And they returned in less than 2 weeks, which was very comforting to us. However, 20% of this small series had a recurrent subluxation in less than 4 months and required surgical treatment. So that there is a danger in classifying patients 1 and 2 and treating the patients conservatively with minor problems and surgically with major problems. The major subluxations had the problems you would anticipate, more than 5 cc's of effusion, a positive apprehension test, that is on reproducing the subluxation. There's pain and contraction of the muscles, and almost all, 15 of 17, had fracture fragments or cartilage fragments. And the range of motion was below 90 degrees with a median of 62 degrees. And all of the major injuries had arthroscopy, lateral patelloretinacular release, reconstruction of the medial patellofemoral ligament, and we used a dynamic tenodesis. And each of these patients who had cartilage or bone fragments had them removed. And we had no complications in this group and no recurrent subluxation of the patella. However, the problem is that this is very hard to sell to high-performance athletes. Requires 6 weeks of immobilization and a minimum of 3 months return to elite athletics. So the dilemma is differentiating between the minor subluxation and the major subluxation in elite athletes. The minor problems can be treated conservatively, but the patient must be warned that there is 10 to 20%, 20% in our series, incidence of surgery within the first year post-injury. The differentiation between the conservative treatment and the surgical treatment is the major difference in returning to full sport activities, and that is a difference of 2 weeks and 3 months, which is significant to the athletes. But none of our patients who went through the surgical treatment and had 3 months of postoperative evaluation, including 6 weeks of immobilization, none of those patients had a recurrent problem. We, of course, checked for generalized laxity and the size of the patella and the classification of the patella, but in these patients, they were basically pre-selected because of their high athletic performance, and they did not have the problems that are generally found in the population with recurrent subluxation of the patella. We intend to do a new study focusing on the Q angle in college non-competitive athletes. Thank you very much.
We have 2 minutes for question from the floor. Please proceed to the microphone. I have one question. Sure. In terms of you consider the MPFL reconstruction, you recommend in the first episode of the patellar dislocation or not?
Yes. Are you asking if in every case was the medial patellofemoral ligament ruptured?
Yes.
In our cadaver work, we found that approached up 100%. There are several articles in the world literature indicating that there is injury in every case of subluxation of the patella, and almost always the ligament heals, but heals in an elongated fashion so that it is non-functional. We believe that those patients are ideally treated surgically, either by tenodesis or direct repair of the ligament.
Okay.
Thank you very much.